Hi, I'm Ralph Preston, and every Tuesday we have these Stroke Buddies Recovery and Science Zoom meetings where we try and bring you some useful and valuable information for your recovery. And today we've got two special guests, Swapna Balakrishnan and Denise Parker Peters, sorry. And they're both doctors of physical therapy. They're also researchers, and Denise is also a professor at the University of Vermont. And they're going to talk to us today a little bit about their study with wearables and mapping stroke recovery, walking, and gait. I'm always interested in things like this because I think that as technology continues, we're going to see more and more use of technology that'll actually help us as stroke survivors in our recovery. So I'm interested to learn a little bit more. I've looked a little bit at their materials, but I'm interested to learn a little bit more about what they're doing. So it's time for me to get quiet and turn it over to them. So welcome and thank you for taking time out of your busy schedules to join us today.
Thank you so much for having us, and I will just share my slides now.
Yeah, thank you, Ralph, for that introduction and welcome.
Thank you. I will start by introducing, and I'll let Dr. Peters introduce herself. I'm Swapna Balakrishnan. I am a physical therapist, and I am currently a PhD candidate at the University of Vermont. I have been conducting this, I have been working in skilled nursing long-term setting. I'm a board certified neurological clinical specialist, and stroke recovery is my area of interest. My clinical experiences actually guide my research, and my experiences with working with patients with neurological conditions actually got me more interested in research because there's so many gaps, and I wanted to address this by conducting clinical research. And that's how I started my PhD program at University of Vermont in 2020. And since last year, my research is live and collecting data on participants. And yeah, apart from research and physical therapy, my interests are swimming, and I also enjoy reading. And now I'll let Dr. Peters introduce herself.
Yes, hi everybody. I'm Dr. Denise Peters. I am an associate professor at the University of Vermont and also the program director of the physical therapy program here at UVM. My background is in walking recovery, both in older adults and people with stroke and spinal cord injury. I also, speaking of neuroplasticity earlier, look at changes in the brain after stroke and how such changes relate to recovery. And again, primarily walking recovery. And I also am involved in some outcome measure research, developing maybe new assessment tools, and getting into the wearable devices that Swapna is going to talk more about. Because yes, while we look at a lot of stuff when patients come into the clinic or come into a research lab, we're finding it's often not indicative of what people do out in their daily environment. And wearable devices give us an opportunity to actually assess what people do in their real life. And it's an exciting avenue to kind of get into because that's where, as PTs, we need to be impacting your mobility and recovery is what you do in real life, not necessarily what you show us in the clinic and lab. So I'm excited to see kind of where technology goes in the next couple of years, because I do think it's going to be very helpful in helping us design personalized treatments for people recovering from stroke. So, Swapna, I'll give it back to you.
The old disclaimer.
Swapna, you're on mute.
Yeah,
Old.
the presenter mode usually messes up my screen, so I
Or
apologize.
not.
Uh, so yeah, just want to start with a disclaimer that whatever recommendations we make today are very general. Please always consult with your healthcare provider for any specific recommendations. Um, we don't have any. Dr. Peters and I do not have any financial disclosures from this talk. So these are some of the discussion points that we are going to go through. And please feel free to jump in when you have questions. This is just meant to be very conversational. These are just points that we want to we want to make sure that we are on track with the conversation. But yeah, we can always take tangents and if that's helpful. We'll first talk about stroke recovery and what are some of the causes of walking difficulty. Of course, it's so variable with stroke. We'll talk briefly about current evidence available, some recommendations that you can take away from today's talk about improving walking, some current research gaps that still exist, and how wearables can bridge that gap. And we'll finally briefly touch upon our research. So let's start by meeting Martha. Of course, the name has changed, but it's very reflective of many of the patients I have seen in the past. Martha is a 64-year-old school teacher and who presented with sudden right-sided weakness one day when she was making coffee in the morning. Her goal was just to return home and do all the things she likes, like walking her dog in the neighborhood. That was the only thing she wanted to get back to. On day two, and as this is a story with most of the patients I collaborate with, the sudden weakness, like initially it's like needed two-person assistance and was not even sure what her future would look like because of this sudden incident and sudden change in her life that happened. But today, it's been almost 18 months and she can walk up to 3 miles with a cane. So this just story reflects that every little bit of win after a stroke matters, and the journey may not exactly look as you hope it should look like, but there is always changes that are you're always improving, and every little win does matter. So I want to just show this image to show that stroke recovery and how you move through the healthcare system is very complex. And as a physical therapist, I may see you at one stage, but if you talk to another physical therapist, they may see a stroke survivor at different stage of their recovery. For example, like when a stroke survivor there's a 911 call, you go into an acute hospital. The goal of a therapist in an acute care hospital would be to get you to determine your functional level and determine which is the suitable next level of care for you. Are you ready to go home? Is it the stroke very minor? Or do you need more intense therapy because you need assistance, but you are still capable of tolerating at least 3 hours of therapy? If you still need a lot of assistance, but 3 hours of therapy may not be for you, they may admit you to a skilled nursing facility. Working as a therapist in a skilled nursing facility, I would see patients in a wide range. I would see patients who come to me from acute care, or they would come to me from an inpatient facility because they were initially thought that they could tolerate long hours of therapy, but it was not quite there. um, I would also see patients who had gone back home, came back to acute care, and then came back to skilled nursing. And if you need like continuous nursing assistance and you are significantly bedridden and you need a lot of help with advanced nursing care, you would be admitted to a long-term acute care facility. So this is the whole, depending on where you are, the therapist goal and the patient's goal will be very, very different. So, as we initially started our talk with principles of neuroplasticity, uh, we recovery after a stroke. Often, this neuroplasticity principles are often used in any one of you who has used physical therapy services would have their therapist speak about principles of neuroplasticity. And also the stage of we long held that belief that if you the first 6 months are the crucial period where the maximum recovery happens and there is no recovery after you enter the chronic phase, but that's not true. The phase of recovery may be slower, but you do not plateau. There is always small improvements that do keep happening. So even after you enter the chronic phase of stroke recovery, you can still work a little bit more, and there is always room for more improvement. And I will let Dr. Peters speak a little bit about this as well.
Yeah, and I think Swapna on another slide, you've got it where I can touch a little bit more. But it sounds like Dr. Hetzler did a great talk about neuroplasticity. And it's true, there are many factors that impact recovery after stroke. Some are non-modifiable, such as age, and whatnot. But while a stroke might cause damage to the brain, there are definitely things that can be done to drive positive changes in the brain that assist recovery. And we'll talk a little bit about that in some future slides of what that looks like. And, you know, more and more research is being done, and a lot outside of this country. There's some good research out of Canada and New Zealand, especially looking at walking recovery, where they're trying to develop predictive models, where early after stroke, maybe within the first week, they look at a couple of different measures, and depending on how patients perform on those measures is maybe predictive of how well someone might achieve independent walking at a certain time point down the road. And a lot of these models are still being tested on a larger scale to see how well they work. But there's some good movement in that field, because then if we can identify early on kind of a likelihood of walking recovery, it can improve our ability to accurately give a prognosis for walking recovery. It can help us target our interventions more, and it can help optimize resources that often are limited to some degree by insurance and what insurance allows. So if we have better understanding of being able to better predict with what time insurance in this country allows us, we could really optimize our treatment in a way that can hopefully be most productive for patients. But we'll talk a little bit more about that, Swapna, I know, in a couple of slides.
So there is like a wide range of reasons someone after a stroke might have difficulty with walking. Some of them may be more overtly visible, but there are a lot of things under the surface that are not visible, like perceptual issues, sensory issues, vestibular issues, and many times many of these deficits may not even be present. So a stroke survivor goes from acute care to home care, or they go from skilled nursing to back to home, and there is like new things that are emerging that they are like suddenly thrown off because there is this depression that was not there. Maybe there is this increasing level of fatigue that was not there. So there is always new things that are emerging, and it's very important to be more aware of that and address those, because you're not even sure what is happening to your body until you are visiting a physician, or you have a fall, or there is some major health crisis that causes you to see a healthcare provider. And that is a big reason why there is a high rate of readmissions among stroke survivors, and or many of them, without addressing these impairments, there is and a lack of taking access to healthcare, there is also many times a downward spiral. So what happens after a stroke, after individuals return home and go back to their community, is often not understood very well. And the big reason for that is we don't necessarily have tools to we have been relying on paper-based measures and asking people what they do. So we don't always have the tools to extend beyond after they are out of the healthcare system. Dr. Peters, would you like to add something?
Nope, not at this point. That's good.
So
This is where I can come in. Yeah, this is a slide. Yeah, so as I said earlier, a lot of times we have patients, they come to our clinic, and we might assess their ability to walk or look at their balance, and they might perform and walk at a certain speed, or exhibit a certain degree of balance impairment, and that might show us their capacity. Like, this is how fast I'm able to walk, right? But that doesn't necessarily mean that's how they're performing in real life or in the community. So, and that's why oftentimes we say what we see in the clinic doesn't always translate into what's going on in real life. And so all because somebody has a capacity doesn't mean that that's how they are performing on a day-to-day basis. So that's why it's important for us to really be able to assess what are people doing out in the community, out in the real world. The second bullet point talks about recovery versus compensation. There's the physiological definition of recovery, which is we are basically firing the same neural pathways that were fired before when walking. And then there's some compensatory recovery on a physiological level, which is maybe we're using new neural pathways, or think of it as like side roads, to maybe do the same thing, which in this case is walking, as we did before. In terms of what it might look like to you as a patient is, are you moving your legs and body in the same way as you did before, or are you kind of moving them slightly in a different way, but you're still able to walk? So are you using an assisted device? Are you not? So in my world, it usually recovery is a combination of both. It's a combination of recovery and compensation to help people just get as independent as they can be with walking. I will say, in the physical therapy world, we used to be focused, like, 20 years ago, 15 years ago, even, on how walking looked. We were really focused on trying to help people move their legs in the same way as they did before. But now the research and evidence has really shifted to, we just want people stepping. We want people stepping. It doesn't really matter what it looks like. We are cognizant of pain, so we obviously don't want to be doing something that is eliciting a lot of pain, but it doesn't have to look typical. That ties into the repetition component of neuroplasticity. We just need people stepping, moving, and we're just less focused on how it looks. And a lot of that research, especially at higher intensities of training, have really shown really good gains in people's ability to walk faster and walk farther. I already touched on the prediction models used to predict recovery. There's some great potential there. Again, looking at some early clinical markers, such things as like your hip extension, or your kind of think of it as your butt muscle strength, or your knee strength in terms of being able to straighten your knee or your quadriceps, and as well as some certain balance metrics. And depending on how you perform early on, can be maybe indicative of your ability to recover walking. But it's not so black and white, and more research is definitely being done at larger scales. But again, as Swapna had said, the demands on your body are much higher often in real life settings than what we do in our clinics. And there's greater stability demands out in the real world, which can drastically increase risk of falls and other types of impairments. So all of this we're kind of thinking about as we continue to hopefully advance treatments in terms of walking recovery and stroke.
So I would just add to what Dr. Peters said, like how when we are out in the, like, research earlier used to be mostly restricted to a lab setting or a clinic or a clean, predictable environment. But when the unpredictability of outdoor environments is added, how your muscles fire or how your stability demands change is very different. And they did this research using EMG leads and actually measuring everything. So far we have been so limited to the lab setting because we didn't have the tools, but now we do have the tools, and we can look beyond what happens in a clinic or a lab setting. So just talking about what are the current recommendations for improving walking recovery after stroke. And this was a locomotor clinical practical guideline developed for clinicians. And the these are based on the research available, uh, based on what is currently being done, and the amount of research that has been done by pulling together all the research that has been done in a period of time, and pooling them together to determine what are the main recommendations that come out of it. And most of the recommendations recommend that stroke survivors should move at when you're doing a walking training. It should be at a moderate to high level intensity. There has to be a strength training component, virtual reality component, cycling and recumbent stepping, like aerobic exercise type activity, but at higher intensities, some strengthening exercises, and also some static and dynamic balance exercise with or without with virtual feedback. But the gist of it is this is recommended more at the clinic, but also when you're doing even at outside, it's always recommended to engage in moderate to high intensity. But the good news is even engaging in some moderate intensity of exercise can significantly reduce risk of comorbidities like a second stroke or risk of other uh, cardiovascular problems. And how can you tell without any complicated devices if you're engaging in moderate or vigorous? So CDC has this talk test guide where if you're engaging in moderate intensity, you can talk, but you cannot sing. And that's how you know you are in moderate intensity. And vigorous intensity is like you are not even able to say a few words without pausing for breath. So if you can, this is a simple way to gauge how you are moving, and that can tell you whether you are moving enough or at a correct level of intensity. Do you want to add anything, Doctor?
Nope, just to clarify that these guidelines are based on people with chronic stroke, so people that are like even years and years out from stroke. So it's not just people in that early time frame. So that's all.
So, what are the some? I want to make sure that, like in our talk, you have something like concrete to take away. Research is now largely focused on behavioral change approaches. Like, how can you incorporate activity in your everyday life? And for all of us, our routines look different, our preferences look different. So it has to be like the principles of neuroplasticity say that it has to be salient. It has to be something that is more realistic for us and that is more interesting for us. So research is now focused a lot on how you can modify your behavior. How can activity be a part of your daily life? As research recommends, some activity is better than no activity. So even if you have like, how can you break your leisure time activity? Like you're sitting on a couch, maybe doing like, gardening, like moving your lawn or vacuuming your house. That is also activity. It does not have to be lifting weights in a gym. So any kind of activity and breaking any type of sedentary behavior is good. So any activity is better than nothing. Again, intensity is very crucial. Like I mentioned, like your intensity is a direct reflection of your cardiovascular health. So as you increase that intensity, more you increase it, the better. And you have to be in the driver's seat. Like I saw a few talks before, and many of the physical therapists who came and who recommended, like, physical therapist is like a service. So what you do in the 1 hour of therapy is just to guide you, and what you do the rest of the day is what really matters. So you have to be in charge, ask questions, do research. So you have to be the driver's seat person on the journey of your health. Your healthcare provider is there to work with you. You are a team, so it has to be a collaborative process. We are going away from the predictive, like prescriptive model, and it has to be a team collaboration. uh, Advocate, like, it is very crucial. You, as a stroke survivor, you have a huge voice, and you have a huge power in advocating. So ask questions, uh, take things to the leadership, like how you can advocate for stroke research, how can you advocate for things to get better. um, uh, your voice really matters a lot. As I mentioned, as you move out, go back to your home and community, there are new challenges that are coming up, and how that affects. If you are not even sure, start writing it in a journal, so that and what are your goals? So keep a journal of how your recovery is, what are the new challenges you're experiencing, and determine goals that you want to achieve. What are the stroke symptoms that are preventing you from doing the things that you like? And those are very important, and those are good starting points to work from. Practice, like whatever you do, whatever is difficult, practice. The more you practice, repetition is again the principle of neuroplasticity that I'm going to go back to. Stroke research, as Ralph mentioned initially, for change to happen, we all have to work together. We have to do research, get findings that are, uh, get good data, and present that to for change to happen. And science is a way to do that, and research is very important. So when it is very these type of research can actually make change happen. So participating in stroke research and finding out because there are so many gaps that still exist, and without that knowledge we will never be able to move forward. And yeah, I touched upon other things, but these are the current recommendations based on a systematic review that was conducted. That it is recommended that stroke survivors engage at least 20 minutes at 3 to 5 days a week at moderate intensity exercise, and at least do 2 to 3 days of strengthening exercises, where you do 8 to 10 exercises for 1 to 3 sets of all major muscle groups. But that's all I had. Dr. Peters, did you have anything?
Nope.
You're mute.
Oh, so I was like, nope, I'm just going to let you go so we can get to talk about wearables here. So.
Yes. So just a quick activity, because we have been listening a lot. So I want to raise a question for everyone. How many of you use wearable devices? Just raise your hand. Great, like, yeah, so a lot of you. And you can jump in and whenever, but what are the typical health outcomes do you currently track with your wearable devices? And you can speak up, like you can unmute yourself. And
I use mine mostly for sleep because I walk with a quad cane and my other side is paralyzed. It is not good at tracking steps. I was on the treadmill in PT this morning, and because I hold on while I'm on the treadmill, it doesn't count any steps. It doesn't know. It does do a good job at tracking heart rate, so I can follow heart rate of my activities, but it's absolutely useless for steps.
thanks, Polly. Yeah, you are correct. Yeah, it does have, the wearables do have some challenges when it comes to movement, especially when your walking pattern is different. So yeah, that's correct. You made a good observation.
Yep, and we'll talk about that in a couple of slides. I'm curious which wearable you have. There's some research grade wearables that are a little bit better at that, but a lot of the consumer wearables just haven't caught up yet to some of that. But it's important to know, because if people are using it and assuming it's accurate, they kind of need to understand that certain metrics on those watches aren't accurate. So
Probably a price point thing.
yeah, if we could, Ralph, we could talk a lot about the potential reasons why, but price point thing, but also there's been a lot of research on trying to improve the sensing capabilities of certain sensors and the algorithms they use to calculate these metrics with different walking patterns. So that is going on. People with Parkinson's disease, for example, and whatnot. It's a different, I mean, atypical walking pattern. And they've made advancements, but getting that then into Apple or Fitbit or Garmin is just, there's that little delay. And then you also have people studying this model, but technology is advancing so quickly that by the time they understand this model, there might be 2 or 3 more models now that might have completely different platforms that it's hard to almost keep pace with the technology advancements, with the research studying stuff to try to improve some of this. So, but I'm getting on my soap note here. Swapna, I'll let you continue.
Anyone else want to
I
talk
have a,
about?
q- I have a question
Yeah.
for either of you. I don't care who. The question is that I similar, but it was spent. I mean, it was a name, and I had the Fitbit. I mean, I had it on my wrist, on my affected side, and I was curious how it would be. And I only took 300 steps all day, and I go, "What? That's insane! I walk more than that. Maybe it's dead on that side, and it needs to be shaken up and smartened up." But I put it on the other hand that was walking all day, and it was very different. So it depends on the quality, I'm sure, like you Ralph had mentioned. But I also believe that maybe, I don't know why. I guess that's what my question was, was it because my arm was not moving or what? I was walking, but I wasn't moving or swinging my arm.
I'm not the doctor of physical therapy, but I'd say it's because you're not doing enough opposition, that it's not picking it up somehow.
Yeah.
When I when I
Go ahead.
put the Fitbit on my left wrist, it actually thinks I'm asleep because my arm is not moving at all.
Yeah.
Must
Yeah,
be the case, yes.
it
I used
depends
to,
on like the sensor and how it's programmed to calculate the metrics from device to device. And oftentimes it is some sort of movement. And so they have done studies where they actually are looking at the optimal sensor site to get the most accurate data. And they've put it on maybe your paretic side and your non-paretic side, and sometimes the legs and sometimes the hip, and they've really looked at which place captures the most accurate data.
Can you speak English? Paretic, non-paretic? What
Start
would we
the side that was impacted by your stroke,
affected.
is
that is your weak side, the one that you said isn't moving that much.
the paretic side? Like, define that. I don't know what you're saying.
That just means weakness. So it's
Paretic?
your weak. Yes.
Paretic?
So
Thank you.
yes.
Okay, thank you.
My apologies, Mindy. Thank you for just helping me to clarify that. So you're right. Most of the time, these devices recommend, or these companies recommend, that you place it on your stronger side, the one that might not have been impacted by the stroke, to get the most accurate assessment.
Thank you.
And Swapna, you can chime in here because you.
Yeah. So, this is something that I also looked a lot for my research. Like, and as you mentioned, a lot of these consumer wearables, they depend on your arm swing. So, when the arm swing is not as much, they don't provide accurate data. And the good thing about research grade sensors, and actually even the earlier versions of Fitbit, they used to have a Fitbit that used to go in the hip called Fitbit 1 that was very accurate. But now that very accurate sensor got discontinued, and they have the mostly the wrist ones. But the sensors that are close to your leg or the hip or the ankle are tend to be more accurate in your step count. And for my research, I asked participants to wear it on the stronger or the dominant side, because the closer it is to the leg, it has a better measurement. And many of the sensors, like Dr. Peters mentioned, the validity of the sensors is not the same with the research. So when we go to study a sensor that is accurate, they are already discontinued by the time we reach there. So the sensors that are in the leg, that many of the research grade sensors that are in the leg are more accurate than the hand one. But yeah, it is always recommended to wear it on the dominant side.
Thank you, Swapna. And to you both. I believe that it kind of leads to, oh, geez, maybe we should understand a bit about what you're buying for technology support, the way that the watch or whatever may work. It's valuable to know those kinds of things. What I might do. I thought if I put it on any part of I thought that if I put it on any side, that it would be measured. I realized that that was not right now.
They make them for the general public, not people who have stroke. We should have some kind of stroke Fitbit or whatever. I use my phone in association with watch. If the phone and the watch are within Bluetooth area range, you don't even have to carry the phone. Also got interested in I'm interested in sensors in general and technology, like I mentioned. So I took the phone and I counted steps. I'd do 500 steps. I put the phone in my hand. I put the phone in my front pocket. I put the phone in my back pocket, and I got 500 steps, or within 1% every time. I strapped it to my leg and got on to a new step, and it didn't measure a single thing, even though my leg's going up and down. It's in the wrong plane or something. So the the technology is there. It could be price point. Also, like I said, they're making them for the general public who just basically wants to see if they're getting in their 10,000 steps and they don't have gait issues or opposition issues. So, but
Yeah, I have just one final comment. I'm sorry, I'll be quiet after this. I recently became part of a study here in Canada, Calgary, working on an app for stroke people. I'm on that now. We'll see where that goes, what they develop, and so on. I will let you know down the road.
Interesting.
well,
Yeah, thank you. And thanks for participating in that type of study, because I think, as Ralph said, and Mindy, as you said, it'd be great to have something more stroke specific, and also then to help educate people buying these different devices, how to maybe wear them for optimal performance, and what works, what doesn't. Because Ralph's right, they're designed on young adults and healthy older adults, and they can quickly design them and get them out to the masses from the consumer wearables. And so these other considerations just don't advance as quickly as the development.
well, they don't. I don't know about what they cost, but I participated in MedRhythms. It's now called InStride 3 times. I tested their product, and there are sensors that are pretty accurate because first time I walked, I was working one-on-one with one of the researchers, and we had a Zoom call, and she said, "You have errant steps with your left foot." And I said, "No, I don't." And she said, "Yeah, they do." I said, I started thinking about it, and I realized I was walking like a dog bone in my circular driveway. So where I turned around, so I said, "Do you have GPS capabilities? Can you draw a map of that and tell where these errant steps are?" And she said, "Yes." And I said, "I'm going to bet you anything they're coming 110 feet apart and whatever." So it had happened when I was turning around. I said, "Tomorrow I'll walk in the parking lot, quarter-mile laps, and you won't see any." And so, and I did, and there weren't any. So the sensors are accurate, and I suggested, of course, that they actually have the therapists look at the GPS map of where the patient was walking before they jump to conclusions about errant steps and stuff. So it's not just the sensors are there, but it's not just the sensors, because the apps have to be smart enough to interpret the information they're getting so as not to give, well, I would call that kind of disinformation. And I was pretty indignant because I don't have errant outlying steps, and to get told I did was, but I figured it out anyway. So, and by the way, when we're done the meeting, I've got $1 million idea for the two of you, and we'll talk about it. I'll give it to you.
And then, like you mentioned, like the devices itself are not smart. So right now we are at a stage that we can't trust the devices completely, and we need some kind of you giving us the personalized self-report, because we need some context behind what was happening instead of solely relying on the devices.
Excuse me, I am from California by Stanford. And last night I found out that Stanford, among other universities in the United States, have a brain gate clinical research to implant a sensor in the brain, and you can have mobility. It's for stroke patients and also for those that have paralysis.
Come back in 10 or 20 years.
Yeah, I haven't heard of that, but that doesn't mean it's not out there.
It's starting. It's starting. They're recruiting people. I signed up for it.
Yeah, they are.
Unfortunately, it takes 17 years for the average study to make it to general availability. Hopefully, one of the things we're going to do with all this technology we keep generating is cut that down. But I don't know. This is a guess, and Dr. Peters is certainly entitled to her opinion. But I think they're going to have a hard time getting it down below 10 or even to 5.
Well,
But that
this
would be
is,
better
I
than
just looked it
17.
up. It's just a stage 1 study, so it's just safety. It's not even outcome measures yet.
Right.
On the other hand, let me tell you that I went to a neurologist, and I've had a stroke since November 2023, November, and he was impressed why he had not given me a muscle relaxer. Well, I started with Baflocan, I think it's called, 10 milligrams, and with 1 week taking that pill, make me really, really tired. I had this fatigue that I didn't want to I didn't want to get up from bed, so I am stopping it. The side effects of a muscle relaxer are more dangerous because it gives lack of stability, drowsiness, and then the withdrawal of that medication, it's hallucinations. I'm really disappointed about the muscle relaxer.
Well, a
If
couple
I could just
things.
interrupt for a minute. This is Bruce Hetzler. Baclofen is the most common muscle relaxer used for stroke patients. But if you want to get off of it, you have to be very, very careful. If you go off of it too quickly, you can develop seizures. So you should go off very slowly under a doctor's care and recommendation. You don't just go off cold turkey. It can take you several months to completely get down to zero, depending on what you're starting out at. So, as I say, it's a common drug used for muscle relaxation. I actually published 2 studies on the effects of baclofen in laboratory rats. Of course, they hadn't had strokes. But the point is, you have to be very, very careful going off of it.
Two things real quick. One is sometimes I give it to you multiple times a day, so this strategy doesn't work. I know a couple stroke survivors who experience the same fatigue issues, and what their doctors did was tell them to take it right before bed, and that seems to help with some people. And I'm just gonna, and it's not the only muscle relaxer or the only solution out there. Polly, you got any suggestions that you could make on other things that
Well, I will
place back?
just say that baclofen has not been shown to be effective for hypertonia, increased, muscle tightness after stroke because of its inability to cross the blood-brain barrier. So, and that doesn't sound like it's her problem, but to talk to the doctor and see if there might be an option that you could use. And I won't recommend, because all of them have side effects and some may not be suited to whatever comorbidities you have, but talk to your doctor about an alternative.
I definitely will. Thank you.
All right, let's get back on the tracks.
Yes. So, like, actually, Ralph, you gave me the route, because, like, I'm going to mention what you just told, which is like the devices are not very smart, and you need some kind of context behind what you're doing. So, self-report. We all think we are moving a lot, but we are actually not very. We always tend to overestimate or underestimate. So even if we use a wearable device, it's very important that we keep a journal, or we keep a note of what we were doing. And if the like Mindy mentioned, like the context, and how if you think you were moving all day, but the device did not record, so it was the device, not you. But sometimes we do tend to overestimate, so the variables have not gotten there where they can do everything. So we need a combination of what we making a note of what we did and what the variable told. And many of the research currently conducted with wearable devices basically have been successful in using telecoaching interventions with wearables. Like, they did one study on breast cancer survivors, where they were able to use a combination of wearables and telecoaching to increase the time spent in moderate to vigorous intensity and reduce sedentary time. We often see, like, a lot of these measures, step count and heart rate are most commonly used, and they are kind of what we can just easily measure. So that, like most studies that you see, there will be a lot about step count and heart rate. Like you mentioned, GPS devices can say a lot about where you move in the community. In fact, many of the GPS measures can also determine preclinical cognitive declines, because they have been associated with many of the cognitive measures. So it can also give us information about how your brain is functioning, like your attention, memory, processing speed. And that can be very helpful if to identify early decline, so that you can go back to rehabilitation without needing a hospital readmission. So these devices do add a lot of value. Dr. Peters, did you want to add anything?
Nope, I'm gonna let you keep going. Nice job.
Okay, if I could comment on one thing, this is Bruce Hetzler again. I do not have a wearable, but my wife has a Fitbit watch, and she likes that because it keeps track of her sleep stages. And in terms of stroke recovery, it is important to get good sleep, especially stages 3 and 4 are what are called slow wave sleep. Slow wave sleep, which is most prominent in the earliest part of the night, uh, is the important part of sleep that basically cleans your brain.
Mm.
Area channels in the brain open up, and more cerebrospinal fluid flows through those channels and cleans away debris like beta amyloid and tau proteins. Those are involved in the development of Alzheimer's disease. And so your neurons are washed, basically, cleaned during those stages of sleep, which are most prominent early in the night. So you really should get as much slow wave sleep as possible. And having a Fitbit, if it uh, is connected to your cell phone, you will keep track of that. I'll be quiet now.
Well, then they show up as deep sleep
Yes,
is the
deep sleep.
lay term for slow wave. So just
Yes,
in case anybody's going, well, my iPhone doesn't have slow wave sleep, but it's a deep sleep is what we were talking about.
that is correct.
Mhm.
Deep sleep. Most
Yeah.
prominent early on in the night.
Mhm.
Deep sleep gradually decreases over the course of the night, while REM sleep, which is when you dream and when you store a lot of memories, increases over the course of the night. So your first stage of REM sleep might just be 5 minutes long, but later on, when you're about ready to wake up, your last stage of REM sleep could be an hour long. And that's usually the only dream that you remember, the last one right before you wake up. But you really will have dreamt about 5 times, each dream becoming long, excuse me, longer and longer. Typically, just the last one that you remember. REM sleep is important for brain development and memory storage. And again, that stage gets longer and longer over the course of the night. You have about 5 cycles of sleep over the night. I'll be quiet.
Thank you so much. Like, that just goes to show there are so many things happening in our body that we don't even realize. And that's why these tools are actually very helpful to us, and we need to make the most of it. And yeah, so I just wanted to give you some concrete tips on what you can take away today. One was like, be aware, be vocal about your challenges that you're experiencing. Maybe if you don't realize, write them down and make a log of what you're experiencing. That can lead you to the right direction. uh your yeah, your wearable trackers can tell you how you move in your day-to-day life. And always challenge yourself, walk on different surfaces, but obviously be safe at all times. Look at your home environment. Is that safe for you? And as you there is are there any changes needed? Intensity of exercises matter. No, like your monitor your day-to-day activity and note down which activities are difficult and what are the challenges, because that is always a great point to start in solving some of those issues. uh, Lifting weights like resistance exercises, aerobic exercises are great for your recovery. Some of the key muscles like your hip, your knee, like sit to stand, step ups. These are some simple exercises that are general and anybody can do, and that would be really helpful. Balance exercises like weight shifting, single leg standing, turning. Make sure your environment is safe and you have some support. But these are some exercises that you can help break the sedentary behavior in your day-to-day life. So these are some simple takeaways.
Are ankle pumps heel raises?
Yeah, yeah.
I
You
thought,
can do it in the bed or you can raise up, but obviously standing is more functional.
oh yeah.
Like dual tasking, like having two or three things to do together, does that throw you off? That is one important area that there's more research being done, and that's very helpful. The more you are able to dual task, the better you can walk outdoors where there is so many stimuli. and you have to
I
pay
have
attention
a
to many
I have a
things.
quick question. Does recumbent bikes help with the improved walking? I notice it's not on the list. Recumbent. Go.
Yeah, so bikes do help, but I just did not include it here because not everyone has access to a bike at home, but they are a great source of aerobic exercises. And if you have access to a bike, you should definitely do it. Like, it's a great way to stay active.
Yeah, it's a great way to stay active. It won't maybe help as much as activities that actually involve direct walking, but it's still really good. And as Swapna said earlier, every little bit counts. So it's going to help with your physical activity, your cardiovascular health, and it might help some with your walking. But the best form of walking intervention is walking itself at these higher intensities. But again, that doesn't mean not to do it. Do it, please. Like, physical activity in any form is just so beneficial. So,
Plus, more movement equals less depression.
It's an aerobic exercise, there is like clear evidence that it drastically improves your mood and reduces risk for depression.
Not
hey,
to mention,
Swapna, do you want to switch to your last slides about your study, just real quick about the sensors? And then we can take questions. I see some that have popped up in the chat for you. So.
Sure. So basically, my research is like a lot of these questions that you raised actually are what I also came across when I was designing my study. Many of the research grade sensors, like the thigh sensor that you see and the ankle sensor, they are very accurate in step count, but they are not even available to the general consumer. So my research basically has a threefold aims. One is to understand how stroke survivors are moving in the community, because so far we've been using paper forms and asking people, well, how, do you move a lot? And they're like, oh, I move a lot, and the conversation is over. But there is more to community mobility, like how far do you move in your neighborhood, extended neighborhood? Do you spend a lot of time away from your home, or do you sort of stay in your home area as well? Because many of the qualitative studies conducted previously, stroke survivors always mention that in light of the new impairments, their mobility level has drastically changed to save energy or decrease difficulty moving because of fatigue and other issues. So first, we want to use a combination of GPS and self-report to see how you move in the community and stay active. And for the second aim, we are going to combine an activity monitor and GPS data. All participants will still fill a log, but we can tell, like, if you're like, for example, we collect 7 days of data. On Friday, every Friday you go to the church, and going to the church maybe keeps you more active, and you don't even realize that you were more active. So maybe increasing that activity. So having that location and the activity data can tell us where in the community do you tend to stay active, and that can lead to valuable conversations. And finally, as actually Mindy mentioned, that the accuracy of the consumer wearable. So Apple Watch has never been studied among people with stroke. So we are actually comparing step count and heart rate data of Apple Watch with research grade sensors. And actually, our initial data already shows that there is some level of agreement. So, the study is 2.5 weeks, and it will be conducted from home. All sensors will be mailed, so you can be anywhere in the US to participate, and all sensors will be mailed to you. You wear 5 sensors during the first and 2 sensors during the second week. And yeah, we will compensate $75 for your time and effort. But most importantly, like, this research can give us a lot of valuable information on how wearables can be used to help improve community mobility and monitor community mobility, which is not even possible now.
Yeah,
And
I think it was just nice that a lot of the questions that came up really tie into a little bit about what you're trying to look at and what we're trying to just get more insight into. I want to make an important note, because I don't want people to feel overwhelmed with technology and all there is, because there's definitely that capacity too, because it's changing rapidly. There's so much out there. So even when we talk about maybe using wearables in the way that we have to help monitor certain metrics, heart rate, step count, you know, you don't have to monitor everything. I think, just pick one or two and know how to use it well to help you enhance your movements. And kind of you can let the rest of the stuff go by a little bit, because if you get overwhelmed, you just might shut down completely and not use it in ways that could be beneficial. So I think to just ask questions. Mindy and several of you guys have done a really good job of asking, and just starting with just a simple few to get going, because it is a lot. And Bruce, I also don't I study wearables. I don't wear a wearable myself. Like you know, um, I use other metrics to help me keep, track of what I'm doing, but it works for some people and it doesn't for others, and that's okay. That's okay. We're here to just hopefully provide a brief overview and some education about it, in ways that, hopefully can be beneficial to you. So.
Well, being the son of a teacher and my wife is a teacher, knowledge is power. I think sharing that knowledge would be beneficial not only to us, but also to others. And therefore, it would be very worth doing.
Thank you. Knowledge is power and choice is power too. Like, we give the knowledge and then people decide what to do with it. And we help clarify and then decide. Both are super valuable. Thank you, Ryan.
Wonderful gift basket.
Also, I would just like to mention, you talked earlier about exercise. My former physician had a sign in his office that said, exercise is the answer to everything. So there's a certain sense in which that's correct. So exercise, exercise, exercise.
I would say that too, Bruce, but I also agree good sleep is too. I'm
Oh,
someone
yes.
who lives in the physical activity world, but firmly believes in quality sleep and try to get that on a regular basis.
Absolutely.
So
Maybe this is a good time to interject. I made a note to tell Mindy, one other thing that came up and all that was BDNF with the recumbent bike, and Dr. Hetzler calls that miracle grow for the brain. And so I just wanted to let Mindy know, and anybody who doesn't have a recumbent, that exercise is one of the best ways to generate BDNF. And there have been studies, blind studies done, where they found that if you ride your recumbent bike, for example, or people who don't have one could walk before they do their therapy, that your therapy is more effective with a half an hour of mild aerobic exercise. So if you can stand it, if you got the energy after you get off the recumbent bike, that would be a really good time to work on your daily therapy routine.
The reason I asked that question is that I do have one, and I was like I don't know what kind of soldier, but I was on that every day. You could see it in the background. It's behind me. And I felt that I felt it wasn't helping. I was on, say, 1 year going diligently, faithfully, and I said, oh, frig, this is not making me stronger. So I slacked off. So it's good to know I should get my butt back on it.
It may not make you stronger, but it'll make you healthier.
Okay, that's a good thinking.
There's nothing better than walking and doing your physical therapy. People look to stem cells and all kinds of other things, and I try and get them to focus on the fact that the answer is, you have the answer inside you in terms of acceptance, motivation, building a daily program. I'm not anti-device, but there are too many people, and I'm not saying anything about you, that try and find a solution outside of themselves. And while they can be useful, well, take stem cells. They haven't figured them out quite yet. I think they will. But, if you think about it, even if they give you a whole bunch of stem cells, they aren't programmed to be you the day before your stroke. You're still going to have to train them. I mean, the whole point with some of these things are, with most of these things are to help you along. I see them as help along with to help enhance traditional therapies. I don't think we're going to get away from physical therapy.
No, I don't think so either. And stem cells in theory are excellent, but these stem cell clinics that pop up are just garbage. It's just nonsense.
Well, they don't work yet. I mean, I've heard all kinds of stories about they couldn't find a vein or something, so they stuck them in her butt. Somebody else, they had them drink them. I mean, you have stomach
Well, it's ridiculous. They harvest those stem cells from the peripheral part of your body in those studies, and then they just inject them into your arm or leg or whatever. And there's a blood-brain barrier. They're never going to get into the brain, and they're never going to get to the site of the stroke. There have only been, I think, two good studies on studies. One was done at Stanford, and in those, they got stem cells from the brain, and they drilled a hole in the skull and inserted a long needle into the locus of the stroke and injected them there. Now, they're not going to do that at any of these clinics that pop up, at the gas station or wherever.
Well,
But in this one at Stanford, what they found was the stem cells themselves died, but they secreted chemicals that helped restore brain functioning. And you're
right.
not going to get that with, again, these pop-up clinics.
Just to comment before you go, Ralph. I believe the under theme or precipice of the comment of the that's kind of going on right now is that it's valuable to have hope, and different things that a person tries may or may not help, but go on and learn from that. So I think that hope is the important lesson out of this. Having hope I will try anything personally. Well, maybe not
Hope,
everything,
perseverance.
but yeah, hope. That's the main thing.
It's real important. Comes along with acceptance. You don't have much hope until you have at least some level of acceptance. But we're
I need to get going because appropriate to our discussion, I had PT this morning and I'm headed to my orthotist to check out my AFO this afternoon. But I did want to know from the physical therapist, I have some concerns about the clinical guidelines for post-stroke physical therapy, for chronic post-stroke physical therapy, and its focus on aerobic activity. And I feel like, I was on the treadmill today and pushing to see how far we can go and, checking my heart rate every minute or so. But it's not helping me walk better. And you were talking about, walking in the community, and walking in the community is so much more difficult than walking in the clinic. And it doesn't seem like my gait, there's any focus on improving my gait so that I am walking better and more safely in community. And your thoughts on that?
Yeah, thanks for sharing that question, Polly. I can say that those recommendations based on the guidelines that were published a few years ago really only looked at the walking outcome of increased walking speed and increased distance, like in a clinic, basically. They're starting to do research to look at that type of intervention and its impact on real world walking. So they're starting to look at that, because that's just not how most of those studies that were pulled into that guideline, what they looked at. They looked at performance in the clinic on speed and distance. That being said, that type of intervention, even if the goal is to get in the moderate to high intensity by checking your heart rate and having you walk, they can also design the walking task in a way that incorporates um, walking in different directions and over stuff and on uneven stuff to mimic more of the real world environment. And so if they're not doing some of that, that could be something that could make, again, I have not evaluated you, so I trust the therapist that has, but it can be more than just treadmill walking potentially, to try to mimic it. But again, more research needs to be done to see what that type of intervention, its impact on real life, because you're feeling the disconnect. And
Well, I would love
so
to be working on gait mechanics, not just, especially with a diagnosis of bradykinesia, that,
mhm.
walking faster and farther just is not in the cards for me.
And that's okay. That's okay. Your goals can be other things because of your overall medical picture. Um, those guidelines, though, were based on those goals, so that's where the interventions come
Right.
from.
And
They
and
weren't
then
wanted to.
insurance is based on meeting those goals. And yeah. Well,
But
thank
again,
you.
this is where working with your therapist on, well, what are your goals? Because they can write it in a way that, like, this is your goal. It doesn't have to be the goal tied to the guidelines. It could be Polly's goal.
Yeah,
And,
they are limited somewhat in, their flexibility around there. They're working in a large healthcare system,
yeah.
so they don't have as much flexibility. I have gone to other clinics and different, more independent, and
Mhm.
worked with virtual. I was surprised how much I enjoyed virtual PT. I thought it was going to be a challenge, but actually doing PT in my kitchen was great.
Virtual is an exciting intervention if you have access to it. So I'm glad to hear you had a positive experience, because that is one that is very evidence based too, like to show some positive impact. So,
Well,
The
thank you very
rehab,
much, and I need to get on the road to the orthotist.
all right. Thanks, Polly.
Bye-bye.
the rehab hospital I was in did me and everybody else a big favor. They had this outside, it was like a lunch area, but it had a concrete walkway, it had grass, it had gravel, it had pavers, it had flagstones in the gravel. And when you got ready, when they thought you were ready, they would take you out there and try some. Well, I think my therapist said we're going to go four-wheeling today. I was in North Carolina mountains, and four-wheelers are a big deal up there. And that made me aware of the fact that, practicing walking, when you practice walking as you're getting better, it's important to include a bunch of different environments. In fact, to challenge yourself, because as we all know, the brain thrives on being challenged. That's how we learn. It gets used to most anything you do regularly. So if you're out there doing the same thing over and over again, that is how you can plateau, actually.
The more you do, the more you can do.
Right. So when I got out, I practiced on, well, I had nobody to hold the gait belt, so I thought, oh, I'll just walk on the grass, because if I fall, it will be better. But I found I wasn't ready for the clumps of grass and ankle. I had to build up my ankle to get rid of the ankle roll, because I didn't want to wear the AFO they gave me, and I didn't, and I managed to build up my ankle. So I had to go to the concrete, which is, there's a real fear factor that you guys might not be aware of, but like, you walk on concrete. I had a friend come and walk me for a week, so I'm 21 days. I'm 28 days out, and I'm on my own, walking on the concrete with nobody on the gait belt, and that's a bit scary. So all you guys need to do is bring in grass, gravel, flagstones, pavers, and concrete into the lab, and make a little four-wheeling track. Okay,
Yeah. Thank you so much.
I'll stop being a smart ass now.
It's all right, Ralph. I
It's
like
my
it.
nature,
I like it a
Ryan,
lot.
you know that. Anybody got any more questions? Well, that's a
No,
rousing.
some of the questions. I did have a general comment. Going for a simple walk, even in my own neighborhood, you get a chance to see nature, you get a chance to see the people, you get to see the world. Doesn't have to be large, a trip to Paris. It's just the joys of the outdoors, the joys of hearing people talk, laugh, birds fly overhead, random squirrels. You never know what you're going to see.
And I think the treadmills are very useful in the beginning because you can hold on to them. I mean, there's a place for treadmills, but the walking's not the same. I prefer, and I live in South Carolina. Well, wherever you live, it can be too hot in the summer and too cold in the winter, so they're good for that, so that you can continue walking rather than give up your walking during the bad weather. But anytime I can, I prefer to walk outside. And Ryan, that's a real valid point about community, because community is the one thing that it's one of the 5 things they'll tell you to make sure you do after a stroke. Sleep, nutrition, exercise, but community. In fact, I've got a video I drop regularly called "The Key to Longevity is Upper Leg Strength," because if you can't get up and down, you're going to fall. If you can't walk, you're not going to get out. If you don't get out, you're not going to be involved in community much, and not being involved in community will literally kill us. Take years off your life sitting around.
Or give you dementia.
You get what?
Give you dementia.
Very true.
If
It
you want
will?
to avoid dementia, one of the factors is being sociable, interacting with other people.
Right.
People like you, Ralph.
Yeah.
It's a big
I have
key.
a question, a final question for
Goodbye,
the,
I have to go.
oh,
Okay.
bye.
Take care. It's been a pleasure.
Sent
Okay.
swap.
That's the,
Just
in my opinion, the
American.
key is either on video, out in the real world, socialization. People need a pack. People need a group. And that just gives us strength. It gives us something to strive for.
Right. I wasn't getting enough, and I started going to church for the first time in 57 years. Mostly to build community. I don't mind the positivity and the messages, but it's real important. It's real important. And too many stroke survivors sit around at home.
Ay, sí, quiero apagar mi teléfono, no puedo.
¿Cómo se apaga?
A ver,
Is the study just American? Swap?
quiero salir del Zoom.
Yes, the studies for the US residents, you have to reside in the US to be
Hi,
participate in the study.
you know,
Okay, thank you.
So, was that Mindy? Because Mindy's in Canada.
Yes, I asked about the study. It is USA only?
Yes.
I ended up having to mute somebody. So I was just making sure. And the answer was yes?
Yes. Only you have to be residing in the US, either on temporary or permanent visa, but you have to be in the US to participate in the study.
Okay. That's always an issue. We got people in the UK that ask about studies and such. So, but they're, especially universities have rules. I saw all those I saw little disclaimers under your graphics.
Yeah. Yeah. Just to unfortunately, like we would love to have more people, but
I get
that's the restriction we have, unfortunately.
I've done this before, and people say, "Well, I have to get my advisor in the university to sign off on it," and then but there's a reason for rules.
Yeah. But we did work really hard to get it to where we could do everything remotely, so people can live in whatever state they live in and can participate, which, took a lot of prep on our end ahead of time to be able to make that happen. So
I think
because we
that's
wanted
right.
to make it more accessible. So
Are you looking for people to enroll?
Are you
Pardon?
looking for volunteers?
Yes, yes, I am.
I came in late. Did you already share how to volunteer?
No, I
Uh,
mentioned that I would, when I posted the video, that I'll also post the links to their study.
okay.
And for everybody out there in YouTube land, in addition to the people here,
Yeah.
I'll put that information in the description underneath the video. There'll be a clickable link. So if you want to participate, you can contact them and see if you qualify.
Excellent. Thank you so much, Ralph.
Okay.
Well,
All the
I
Can
do it
I
with
add some
everybody.
things?
Go
Can I
ahead.
add some things that as I was listening,
yes.
thoughts that I had? I use my watch for steps, but I go into my phone and view my asymmetry as well as my step length, 'cause I want to improve both of those. And
Right.
some days it's pretty good and some days it's not. And typically I find that the better days are when I am listening to music as I'm walking.
Yeah, music does help a lot
Yeah,
with regard to
yeah.
your step
Love
length.
music.
I love my iPhone, but I'm not so sure about the asymmetry thing because I'll have like a 0.5%, which is very, very good. Anything under
Oh.
5, they say, is acceptable. One day, the next day it'll be 34%, and then I definitely, I just, I do a lot of testing. Like I said, I tried this strapping it to my leg on the new step, putting it in my back pocket, front pocket, carrying it and everything, and counting steps and checking it. So I don't know how to test the asymmetry on here, but I'm not so sure it's accurate, Jerry.
But it's helpful just to have a goal and to be looking at it and be encouraged by when I see a good number. If I don't see a good number, sometimes I'll think, whoops, I had a bad day. And some days I'll go, I don't understand why it's a bad number today. I don't see a downside to it anyway.
Yeah.
The other thing that really has helped me, there are two things that have really helped me. One is I use the Walk Fit app. There are a lot of movements that they have you do, routines. And if I'm not walking very well, I go right back to Walk Fit because it kind of takes me back to jazzercise sort of approach. And the other thing is I recently joined a gym called, this one's called Exercise Coach. It's one of those facilities that does the 20-minute routines, exercise routines to build strength. And there's actual, you get feedback as you're doing it, and you get feedback as far as the improvements you've made. And my walking has definitely improved. And I think I'm going to attribute that mostly to this new method of strength training that I've been involved with.
Okay, here's my asymmetry. There are 2 days in a row there of 0, not even anything, 0. And then 2 days, one before and after of 15%. I don't believe it. I don't believe it.
I'd believe, well, I don't know if I'd go with 0, but I'd believe the lower side for myself personally.
I
You know, I
like
think,
I like
yeah, go
the
ahead, Rob.
0.
Yeah, I think it's important that, as you said, Jerry, like you have something that you can look at to help motivate you, to help keep track. It is important, just like in the context, so to realize that, you know, there are some inaccuracies there. But if you're using it in that way and understand that it's in the context of there being some inaccuracy, like that's okay, because it's motivating you to do certain exercises and activity that you are reaping and feeling the benefits of. So, yeah.
There's a 20% with 5 days of 0 and before it and 5 days after. I mean,
Yeah.
Okay, Ralph.
Yeah.
Okay, you've made your point. I taught
Well,
marching band for many years, and off the top of my head, I can't remember the step size. But we try to get students to do exactly the same step size all the way through. And I am achieving a little bit further than that, which is very encouraging.
yeah, we focused our talk today a little bit more on the assessment side of how wearable devices are used, but they are definitely also used to promote behavior change too. And there's a lot of research in that as well. So,
they didn't exist. My stroke was 17 years ago, and stuff like this did not exist then. So I worked very, very hard. The thing about outliers, I said earlier, I know I didn't have outliers because my foot pointed out. I stepped out. I worked really hard at putting each foot straight in front of each other. And then I noticed that there weren't enough, that my gait on one side was shorter. And I worked with I'm not a PT, but I've worked with 14 people in person, one of them for 5 years under the direction of PT. I discovered if you want to improve your gait, you take a bigger step with your unaffected side. Sounds backwards, but hopefully, Denise, you're nodding your head because you agree with me. Has to do with the fact that you don't weight bear very long on your unaffected side. And typically, if people have gait abnormalities in terms of symmetry, especially in the early stages, God, why am I doing this? I always do this in front of 2 doctors of physical therapy, and I don't have a bit of education other than the one I gave myself recovering and learned by helping other people. But so I focus on getting people to take a slightly longer step each time with their unaffected foot, and that will help with symmetry, and maybe that'll help you, Jerry.
Well, and what I try to concentrate on is my affected toe, is staying on that toe longer, try to build that strength up, because that's when I tend to shorten my stride a little bit. But I agree, I do take the longer stride, and then I really make a point to remaining on the toe a little longer and then pushing off.
Well, also, if you have issues with that toe, that'll make you, you'll tend to not weight bear on that as long if you're having issues, and then that's really what you want to do. Have you ever tried the monster walk or John Wayne walk? Slightly
Yeah.
wider stance
Yes.
that'll force you to weight bear evenly.
Yeah.
You can't do, like, I have a small amount of hip weakness still. No matter what I do, I don't seem to be able to get rid of it. But if I John Wayne or monster walk, it's not there. As soon as I start trying to bring them back, it comes back. I'd love to find somebody who knew how to take that John Wayne walk and convert it to move it back in and maintain the benefits of the even weight bearing. So it was a great discussion. We got off on all kinds of things that I didn't know if we were.
I love tangents sometimes. It's great. All of it is pertinent to what's going on. So
Very true. Tangents are great.
We have a fairly concerned community and a community that, well, look, a bunch of people showed up today. We're back to knowledge is power. That's why I do this. I feel like a focused approach is better than a non-focused approach. And how do you take a focused approach? You learn stuff and you apply it to your recovery. So people here are, fairly savvy. I mean, there isn't anybody here that doesn't know, about neuroplasticity. And we've all listened to Dr. Hetzler, by the way, has done 9 presentations. Spasticity, sleep, language, all kinds of things. He was a magician too. He did a really cool one on mentalism, magic, and the mind. How magicians use the sleight of hand and things to trick the brain, which is all that you're trying to do in mirror box therapy, isn't it? Anyway, so basically we believe that paying attention to what we're doing and what we discover, at least I believe this, and there are a number of other people. If you listen to your body and you pay attention to what's going on with you, you can learn a lot. Like Yogi Berra said, you learn a lot just by observing. Anyway, so I know several interventions that we as stroke survivors have come up with that I think need to get fed back to the medical community, but that's a whole another big old can of worms subject we go into for hours. So, if anybody's got any more questions, fire away. Otherwise, I'm going to thank these kind ladies and
Thank you so much for all
Yeah,
the
thank you so
information.
very much, all of you.
You're welcome. This seems to be a really great group. And I'm glad you guys do it. It sounds like on a weekly basis almost. So yeah, that community aspect.
Well, we're creating an archive. Like I said, this technology may change, but a lot of the concepts really haven't changed. I haven't seen them change in 17 years since my stroke. So it'll be out there, evergreen, as they say in the corporate world. Oh, I hate those corporate terms. Anyway, and for a reminder for anybody who tuned in late on YouTube, the contact information for Swapna and Denise will be, and the study will be in the description underneath this video. So
Yeah.
thank you. We appreciate
You're
Thank
it.
you,
welcome.
Rob.
Thanks, everybody.
Do all you can with what you have, in the time you have, in the place you are. Do all you can. Do all you can.